In this video introduction, we will discuss respiratory distress syndrome, RDS, in newborns, focusing on its causes, symptoms, diagnosis, treatment, and prevention. By the end, you will have a thorough understanding of this condition's impact on neonatal health. Surfactant is a critical substance in the lungs that helps in their development and proper functioning. Premature newborns often have inadequate surfactant production, resulting in surfactant deficiency and lung immaturity. This leads to respiratory distress due to the collapse of alveoli, which increases with lower gestational age. In infants with respiratory distress syndrome, alveolar collapse and atelectasis are common occurrences due to surfactant deficiency. Alveolar collapse refers to the incomplete expansion of the alveoli during the respiratory cycle, whereas atelectasis refers to the complete collapse of alveoli. The absence or insufficient production of surfactant leads to increased surface tension within the alveoli, causing them to collapse during expiration. As a result, the affected alveoli become non-functional and unable to participate in gas exchange. This significantly impairs oxygenation and ventilation, leading to severe respiratory compromise. The pathophysiology of neonatal respiratory distress syndrome is multifaceted and involves various mechanisms. As mentioned earlier, surfactant deficiency and lung immaturity are the primary factors contributing to the development of RDS. The insufficient production of surfactant impairs lung compliance and triggers alveolar collapse. Additionally, the immature lungs are characterized by reduced structural integrity and increased pulmonary vascular resistance, further exacerbating the respiratory compromise. The inflammatory response and oxidative stress also play a role in the pathogenesis of RDS. Understanding these pathophysiological processes is crucial for effective management and targeted therapeutic interventions for newborns with RDS. In the section on risk factors and prenatal predictors for neonatal respiratory distress syndrome, we discuss how prematurity, maternal conditions like diabetes and hypertension, and prenatal markers and measurements can be used to identify infants at risk. This knowledge helps healthcare professionals intervene early and improve outcomes. The clinical presentation of neonatal respiratory distress syndrome is characterized by respiratory distress shortly after birth. Affected infants often display tachypnea, nasal flaring, grunting, and retractions, all signs of increased work of breathing. They may also exhibit cyanosis due to inadequate oxygenation. The physical examination may reveal subcostal and intercostal retractions, paradoxical chest wall movements, and decreased breath sounds. It is important for healthcare providers to recognize these clinical manifestations promptly to initiate appropriate management and ensure optimal outcomes. The diagnosis of neonatal respiratory distress syndrome is primarily clinical, based on the characteristic signs and symptoms mentioned previously. However, several diagnostic criteria are applied to confirm the presence of RDS and differentiate it from other neonatal respiratory conditions. These criteria include radiographic findings consistent with ground glass opacities, decreased lung volumes, and air bronchograms. Additionally, blood gas analysis typically reveals hypoxemia and respiratory acidosis. By ruling out other potential causes of respiratory distress, healthcare providers can confidently diagnose RDS and initiate appropriate management strategies. Radiological assessment is crucial for detecting and tracking respiratory distress syndrome in newborns. Chest X-rays are commonly used and show lung abnormalities consistent with RDS. Lung ultrasound can also provide valuable information. Monitoring these findings helps guide treatment decisions. Neonatal respiratory distress syndrome requires a comprehensive approach. Non-invasive interventions like NCP-AP and HFNC improve respiratory support. Severe cases may need endotracheal intubation and mechanical ventilation. Monitoring and adjusting respiratory parameters are crucial for optimal outcomes. Exogenous surfactant administration is a highly effective and safe treatment for respiratory distress syndrome in newborns. It improves lung function and reduces mortality and the need for mechanical ventilation. Other current therapies include surfactant with NCP-AP and aerosolized delivery. Research aims to enhance delivery and explore new treatments. Respiratory distress syndrome can lead to various complications and have long-term effects on respiratory function in affected newborns. The most common complications include bronchopulmonary dysplasia, BPD, pneumothorax, pulmonary hemorrhage, and nosocomial infections. BPD, a chronic lung disease, is especially prevalent in preterm infants with RDS who require prolonged mechanical ventilation. Long-term effects on respiratory function may include decreased lung function, increased risk of respiratory infections, and persistent respiratory symptoms into childhood. Timely recognition and appropriate management of these complications are paramount to optimize long-term outcomes for affected infants. In newborns with respiratory distress syndrome, several factors influence the overall prognosis. These include gestational age, severity of respiratory distress, need for mechanical ventilation, and presence of complications. Understanding these factors helps guide management and estimate outcomes. Prevention strategies and antenatal interventions play a crucial role in reducing the incidence and severity of respiratory distress syndrome in newborns. Prenatal administration of corticosteroids to women at risk of preterm delivery has been shown to accelerate fetal lung maturation and reduce the incidence and severity of RDS. Antenatal administration of surfactant and novel approaches such as intraamniotic instillation of surfactant are currently being investigated as potential preventive measures. Proper antenatal care, timely identification of at-risk pregnancies, and appropriate management of preterm labor are essential to optimize lung maturation and minimize the risk of developing RDS. In conclusion, respiratory distress syndrome in newborns is a complex condition that affects their breathing. Understanding the causes and identifying high-risk infants is important in diagnosis and treatment. Various interventions and monitoring are necessary for optimal care and prevention of complications.